Welcome to our session for auditing medical records. My name is Stacy Olson, and I'm a certified professional coder with a specialty credential in evaluation and management services through the American Academy of Professional Coders. Hopefully you have already had the chance to review the online sessions for history, exam, and medical decision-making, which are used for complexity-based E&M coding, as well as the time-based E&M session. If not, I strongly recommend listening to those sessions first, otherwise the content of this session will not make much sense. CPT is the code set used to report professional medical services. CPT codes are developed, maintained, and copyrighted by the American Medical Association. Every attempt has been made to provide you with accurate and current information, but the coding rules can and do change, and it is always the provider's responsibility to know the state and federal rules and to remain current on payer policies. Today's information is not legal advice or a reflection of any individual health system's policies or procedures. It is not instructing providers in the services they may perform and/or bill, but rather is meant to inform you of general knowledge and best practices for auditing medical services. Our objectives for this session will be to illustrate the importance of auditing provider documentation and its relationship to your revenue cycle. We'll define what auditors are assessing when they review documentation, discuss the goals of internal audits and what to do with the results, identify when external audits might happen and what steps to take, and dissect and audit several provider visit case studies to determine the level of E&M supported by the documentation using the WSPA auditing tool. This picture is probably what comes to mind for providers when they think of auditors, and I would say it's pretty accurate. We are looking at everything through a magnifying glass. We are looking to make sure there is a date of service, that the code criteria for E&M services is met, or if time statements and content are present to support time-based E&M codes. We are looking at who documented what and making sure that signatures are valid and present on progress notes and orders. We are also making sure that if supplies were billed or some other type of service was provided, that they also are thoroughly supported by documentation. And if payer policies apply to a service, we make sure that all of the indications for coverage have been met. Having a robust internal auditing program can reduce the risk of an external audit occurring. Auditing E&M codes is a combination of utilizing CPT and CMS guidelines and using the Marshfield tool methodology for assigning a point system to a provider's assessment and plan documentation to determine the overall medical decision-making. Internal audits should be viewed as a quality control measure. They can provide opportunities for improvement. Audits compare the CPT, HCPCS, and ICD-10 codes billed on the claim form to the provider's documentation. Internal audits are a way to proactively minimize your risk. They can give you peace of mind that providers are documenting and billing appropriately, but can also identify areas where more focus is needed. They may identify providers who are struggling and need additional education to understand what is required to meet code criteria. They also identify undercoding, which is missed revenue. But there is a misconception that if a provider is undercoding, that there is no risk involved, which is not true. If the service is undercoded, it is still not coded correctly, and patterns of undercoding can open your practice to a payer audit just as easily as overcoding patterns. Audits can also identify misuse of EHR functionality. Auditors are looking for acceptable signatures and who performed and documented what in the medical record. We are looking for cloning of notes, such as copy and paste functionality misuse, over-documentation, and fabrication. It is likely that provider documentation will be reviewed by multiple sources, and providers should realize that by signing a note, they are attesting that everything in the note was performed by them during the day's encounter with that patient. So note content should always be reviewed prior to the provider signing the documentation. Audits can be performed from a random sample or if there is an area of concern, the services to be audited would be obtained from a more focused and narrowed sample. Audits can be performed retrospectively, which occurs after the claim is sent to the payer, or prospectively, which occurs prior to claim submission. Prospective audits are obviously preferred, but can slow down the revenue cycle. To get started with an audit, you will need to know what you want to accomplish with your audit. What will the scope of the audit be? Will the audit be random, or do you want to focus on a particular service or code set? Do you only want to audit services from a particular time period, provider, or setting? There are many sources available that can guide you to areas of risk that you might want to focus on. For instance, you could review the OIG's current year work plan, look at denial trends for your practice, or review payer policies for the services that you render. You will need to obtain copies of the medical record, claim form, and the payer's explanation of benefits if the audit is performed retrospectively. You will need to know the state and federal laws and payer policies for the services that are being reviewed. The organization's internal policies and procedures should also be applied, as well as the coding guidelines for CPT, HCPCS, and ICD-10. You will also need an auditing tool. This can be a paper form like the one that the WSPA put together and we will work on today, or there are many vendors to choose from for auditing software. Make sure that you have a qualified person complete the audit. If the staff does not have the appropriate training to complete the audit, consider hiring a consultant to help you. Having someone who is experienced and knowledgeable about the specialty or service that is being audited will produce more accurate results. I strongly encourage you to invest in employed coders and provide them with the resources they need to become the experts you need them to be. This investment will pay off by reducing risk and maximizing your revenue. The person performing evaluation and management audits should be a certified coder through the American Academy of Professional Coders and ideally hold a specialty credential in E&M or auditing. And if there is a previous audit available for the services being audited, obtain a copy of those results for comparison. The audit is complete, so now what do we do with it? Analyze the source of any incorrect coding or billing errors. Is the error occurring because there is an improper workflow in the clinic? Is the provider not documenting appropriately? Is there a system mapping error for codes? Did the coder or the provider make the error? Distribute the results of your audit to the appropriate people. Who the audit results are distributed to may change from audit to audit depending on the scope of the audit. Results typically go to the provider, clinic manager, and service line directors, as well as other identified leadership members. If you are auditing coders, the results would be sent to them, along with their immediate supervisor. I do recommend having quality assurance audits for your coding staff, in addition to auditing your providers to make sure that coding guidelines and internal policies and procedures are being met. Education needs to be provided to the individuals responsible for the error or to the departments responsible for correcting errors that are occurring in the system. When audits reveal mistakes in coding, whether it is overcoding or undercoding or an ICD-10 correction, corrected claims can and should be sent to the payer. If you are within the payer's timely filing limit for claim submission, the claim will be reprocessed and payment or recoupment may occur. You will need to refund any overpayments that have been identified following the contractual agreement with the payer. And you should continue to monitor identified risk areas to make sure that improvement is occurring and that the same problems do not continue to happen. If a provider did not receive a satisfactory score on their audit, education should be performed for the areas of concern, and the provider should be re-audited after they have had the opportunity to make adjustments to their documentation. This process should occur until the organization is satisfied that the risk has been minimized. External audits may be performed by a payer or a third party. Medical practices are audited all the time. Payers use software programs to compare providers with others in their specialty to identify abnormal coding patterns. More providers than ever are being asked to send in charts and other documents for review by payers. You will want to identify who is performing the audit and why it is being performed. Not all audits are routine, and it's important to make sure you know who is asking for charts and the reason for audit before shipping off requested documents. While a payer's request for medical records may simply be for a purpose in the ordinary course of business, a request for medical records could also stem from a review of a provider's utilization of services or from some other suspicion. Third-party payers frequently contract with outside vendors to review medical records and to conduct audits. Unfortunately, these companies do not always identify the payer on whose behalf they are working or the type and scope of the audit. This is critical information that the practice has a right to know. Pay attention to deadlines and procedures for record submission. Designate an individual responsible for responding to medical audits and for keeping the providers informed of its progress. Among other things, this individual should calendar all deadlines and document and retain all communications between the practice and the auditors. If a request for medical records or an audit letter includes a deadline for providing the requested information, the practice should respond timely or immediately seek an extension. In addition, if the request does not specify a deadline, the designated responder should ask for a deadline. This individual should also verify how and where records are to be submitted. For example, can they be submitted electronically, or must paper copies be provided? Make sure you understand a payer's appeals procedures and make sure to file a timely appeal of any erroneous audit finding. Understanding a payer's appeals procedures is important and can have a significant impact on the ultimate result of the audit. When you receive an audit demand, look for the following red flags that may have prompted the audit. Have you recently started billing for new services or items? Have you switched your billing company or billing practices? This can mean a switch to a new system or following new guidelines which you believe apply to your practice. Has an employee with knowledge about your billing practices recently left? Was the departure on good terms, or is it possible that you have a whistleblower situation? Has anyone questioned your supervision standards or other components of your practice which may relate to billing and reimbursement? Have you had a visit from a payer representative asking questions and requesting an educational meeting? These are only a few of the situations which can precede an audit or investigation. If you are not already running independent audits on a regular basis, any one of these red flags should prompt you to do so. So what is the appropriate response to a record request? Pull the requested charts and make sure that all relevant information is compiled, including claim forms and other documents, as quickly as possible. This will allow the practice the time needed to do its own internal audit or have an outside auditor review the charts. Remember that you cannot alter the charts, but it's helpful if you can determine the reason the charts are being requested before they are submitted. Make sure to retain copies of all records submitted for review. When the charts are submitted, include a cover letter which shares any findings from your own internal audit, the steps that have been taken to correct the problem, and if appropriate, reimbursement for the claims related to the requested charts. Consider consulting a billing expert for the audit. This is especially important if you handle your own internal billing and use self-trained billers. You cannot rely on the same person who oversees your day-to-day billing to complete an audit of their own work. Depending on the size and type of audit, consider having independently retained auditors hired through legal counsel. If there are findings that present legal concerns, the legal privilege may provide some additional protection. Remember that anyone you hire to review your charts will be accessing patient health information. All appropriate HIPAA safeguards are required. Talking with legal counsel is always a good step. Audits can be the start of something bigger depending on who is making the request. Payer audits, charts requested through subpoena, and other similar scenarios are indicators that legal advice is absolutely required. It is important to understand the definitions of fraud, waste, and abuse, and to be on the lookout for any situations that could be construed as fraud, waste, and abuse when auditing. Fraud is the intentional deception, misrepresentation, or concealment which could result in some form of personal gain. Waste is generally understood to encompass the overutilization or inappropriate utilization of services and misuse of resources. This is typically not considered to be a criminal or intentional act. Waste by a provider could include ordering excessive laboratory tests such as a comprehensive panel when only one test is needed. Abuse describes practices that either directly or indirectly result in unnecessary costs. Abuse includes any practice that is not consistent with the goals of providing patients with the services that are medically necessary, meet professionally recognized standards, and are priced fairly. Abuse can expose providers to criminal and civil liability. Intent does not have to be proven to end up in trouble. This slide lists some examples for fraud and abuse. Fraud is knowingly billing for services not furnished, supplies not provided, falsifying records to show delivery of such items, billing for appointments that the patient failed to keep, or billing for services at a higher level of complexity than the service that was actually provided or documented. Abuse would be billing for services that were not medically necessary, excessive charges for services or supplies, or misusing codes on a claim, such as upcoding or unbundling codes. So let's look at some case studies and then audit them out to determine what level of E&M code is supported by the documentation. Our first case study is an 80-year-old female seen in the office who was referred by Dr. Bruce Wayne to review and discuss therapy options for osteoporosis with the goal of starting bisphosphonate therapy. She was originally flagged by her insurance as having a previous fracture with no osteoporosis therapy, and when she was contacted late last year, the patient was not aware that her spinal surgery was associated with a spinal fracture. The provider discussed the surgeon's prior notes with the patient and that he had recommended she follow up with a DEXA and therapy post-surgery, which had never been done. The patient agreed to have the DEXA, and that was completed in late January. The patient and the provider had recently discussed the results of her DEXA scan, but they went over these again today in more detail. The patient had started miacalcin nasal spray in early 2015 after the laminectomy. This is a short-term medication to be used around surgery, and then more effective therapy should be started based on the DEXA results. They discussed the difference in treatment options for osteoporosis and the risks and benefits of each. The current recommendation would be to start her on a bisphosphonate to maximize the bone density. Patient is happy to do this, but would like to wait until the current prescription of miacalcin is finished, as she had just picked up a new bottle. They updated the patient's supplements on her medication list. The patient named multiple supplements that were not included on the list. They discussed the use of cranberry with her warfarin, and she stated she had never had an issue with INR fluctuations, although she knows cranberry can increase risk of bleed and she will monitor for those issues. Slide 2 for Case 1 lists the DEXA scan findings from January 20th, 2016. It states the lumbar spine could not be evaluated due to the previous fractures. However, the T-scores at the left hip and left forearm are consistent with osteoporosis. We also see the allergies to several medications documented and the reactions for each of those medications. Slide 3 for Case 1 is a full list of the patient's outpatient prescriptions that had been updated during this encounter. Slide 4 for Case 1 documents the patient's vital signs, and the assessment and plan states that Fosamax 70 milligrams weekly was discussed with the patient regarding what to expect, potential adverse effects, how to take the medication, and monitoring. They will monitor her renal function and repeat DEXA in 1 to 2 years. She has been given an informational guide about the Fosamax, and the prescription was sent to her pharmacy. The patient does take vitamin D and calcium, and she will continue to exercise regularly and increase her walking. The The patient will finish her current bottle of miacalcin before starting the once-weekly Fosamax. Contact information was provided to the patient, and she will reach out if there are any questions or concerns. Information on Fosamax was provided to the patient, and she feels comfortable with therapy. Outreach will be performed in 1 month to follow up regarding the therapy. And then we see a time statement documented. 25 minutes were spent today, with greater than 50% spent face-to-face. The provider included a time statement. However, the time statement is not sufficient as it does not tell us how much time was spent in counseling and/or coordinating care. The wording for time-based coding needs to be just right. It needs to state the amount of face-to-face time, the amount of time spent counseling, and the details of the counseling. Even though this provider documented the counseling content very thoroughly, the time statement reads as if only a portion of the 25 minutes was spent face-to-face, and therefore this case must be coded using the key components for complexity-based E&M codes. I would like to draw your attention to the directions in the history section before we go through Case 1. They state to determine the levels of HPI, ROS, and past medical, family, social history. Circle the entry farthest to the right of the table which best describes the HPI, ROS, and PFISH. If a column contains 3 or more circles, draw a line to the bottom of the column to indicate the history level. If there are no columns containing 3 or more circles, the circle farthest to the left identifies the type of history. So let's get started with auditing Case 1. The chief complaint is documented as discuss therapy options for osteoporosis with a goal of starting bisphosphonate therapy. The HPI elements supported are modifying factors for the miacalcin the patient is already taking. Context is assigned for the laminectomy due to the spinal fracture, which was when osteoporosis was suspected, and the duration is credited for 2015. This gives us a total of 3 HPI elements, so following the directions, we would circle the highest level to the right, which would be the second column. Under the review of systems, the allergic system is credited for the documentation of the patient's positive allergies to certain medications. The hematologic system is credited for no INR fluctuations. This gives us a total of 2 review systems, which is an extended ROS, and we would circle the third column. Under past medical, family, and social history, the provider did document a full list of the patient's current medications, which is credited as treatments under past medical history. This would give us a pertinent PFISH, and we would circle the third column. We do not have 3 circles in the same column, so the circle farthest to the left identifies our history, which is an expanded problem-focused history. For the exam in Case 1, the provider documented 5 vital signs, which is credited under the constitutional system in either the 1995 or 1997 guidelines. 1 system meets the requirement for a problem-focused exam. Under the diagnosis and treatment options in medical decision-making, the provider stated that she had previously discussed the DEXA results with the patient. So we know that this is an established problem which is unchanged or uncontrolled. We would enter 1 in the number column by the established diagnosis worsening not controlled unchanged category and multiply that by 2 points, and so our result would also be 2. Since this is the only problem addressed in the encounter, we have a total of 2 points in the diagnosis and treatment options. For the amount and complexity of the data to be reviewed, the provider reviewed the DEXA scan results, which is credited under review or ordering radiology tests, and that is worth 1 point. This is the only work done in this element of medical decision-making, and so our total in this element is 1 point. If the provider had listed the source and date of the surgeon's records which were reviewed to provide a reference point, I would have credited them 2 points under the review and summary of old records. However, without a reference point to go back to, I did not give them credit for this work. Looking at the table of risk, the patient has one chronic problem which is uncontrolled, and Fosamax was prescribed, which gives us prescription drug management. Both the presenting problem and management option in this case fall under the moderate level of risk, so that is assigned as the overall risk for this encounter. Remember that the highest level of risk in any category will provide the risk for the encounter. You don't need to meet in 2 out of the 3 categories on this table. They just both happen to fall into this level of risk on this case. To determine the overall medical decision making, the directions in this section tell us to circle all of the columns to the left of the highest score for each element of MDM. The column containing 2 or 3 circles farthest to the right determines the overall MDM. When we apply this case to the table to determine the overall MDM, 2 of the 3 components are met in the low complexity column, and therefore the medical decision making assigned to this case is low. We were not able to use the provider's time in this case due to the time statement not containing the correct wording. On the auditing tool, we were only able to answer yes to 1 question on the time-based billing assessment, and that means we must code this case based on complexity. This slide represents the documentation from the case that was credited in each key component for you to reference later. I will not go through this slide in detail since I have already spoken about these things in the previous slides. When we are trying to decide what E&M code is supported for Case 1, we know that this is an established patient visit and we need to meet 2 out of the 3 components. Our history was expanded problem focused, the exam was problem focused, and the medical decision making was low. Therefore, we have met 2 out of the 3 components for CPT 99213. This was a missed revenue opportunity because I think the provider's intent with documenting the time statement was to say that they spent 25 minutes face-to-face with the patient and greater than 50% of that time was spent in counseling, which would have supported CPT 99214. The counseling content was thoroughly documented. However, because of the wording in the time statement, the service needs to be coded on complexity, which will only support billing 99213. Case 2 is a patient referred by Dr. Jones for hypertension management. She is accompanied by her daughter and they brought in the medications except her insulin. She has an appointment with Dr. Smith at the end of the month for diabetes. Her blood glucose logs demonstrate 4 times daily, and there was only 1 low blood glucose, which was 52 and without symptoms. They reviewed how to treat low blood glucose and the patient's medications. The patient is knowledgeable about her medications, their purpose, and how often she should take them. We also see the patient's vital signs documented, the current hypertension medications, and the home blood glucose monitoring levels for fasting and pre-dinner. On this slide, we see the provider's assessment and plan for Case 2. The patient's blood pressure is within target range today. If her blood pressure is elevated in the future for long-term treatment, changing from metoprolol to carvedilol may be an option to lower the patient's blood pressure and allow the possibility of discontinuing the felodipine. The patient's incidence of low blood glucoses has much improved, and this change to a non-cardioselective beta blocker could be made safely. The plan states that the patient is to continue her current blood pressure medications, new prescriptions were sent to the pharmacy, and the patient will need an A1C in 2 months. The patient can receive a PCV13 and is completely current on all other vaccinations. The chief complaint is documented as hypertension management for Case 2. The HPI elements supported are modifying factors because the patient is checking their blood sugar 4 times per day, which is helping her maintain her blood sugar levels. Severity is credited for the blood sugar and blood pressure readings at home. This gives us a total of 2 HPI elements, so we would circle the second column. Under the review of systems, the immunologic system is credited for documentation that the patient is current on all vaccines except their PCV13, and the endocrine system is credited for the patient's one low blood glucose of 52. This gives us a total of 2 review of systems, which is an extended ROS, and we would circle the third column in this element. Under the past medical family social history, the patient's hypertension medications are listed, which is past medical history. This gives us a pertinent PFISH, and we would circle the third column. We do not have 3 circles in the same column, so the circle farthest to the left identifies our history, which is expanded problem focused. For the exam in case 2, the provider documented 2 vital signs, which is credited under the constitutional system. However, the 1997 guidelines state that 3 or more vital signs are required to meet the bullet criteria, and therefore we do not have any exam in 1997 guidelines, but we do have a problem-focused exam in 1995 guidelines, which does not have any specific numeric requirement. Under the diagnosis and treatment options in medical decision-making for case 2, the hypertension status is not really stated. However, the patient was at goal, and so this is credited as an established, well-controlled problem. The diabetes is stated as much improved, so this is also credited as an established, improved problem. Therefore, we would enter 2 problems under the number column in this category of diagnosis and treatment options. We would multiply the number by the number of points, which is 1, and this would give us a result of 2. Since there were no other problems addressed during the encounter, the total points assigned in diagnosis and treatment options is 2. The provider documented that the patient will need an A1C in 2 months, but the note does not state that an order was placed. Reviewing home blood sugars does not count as lab review. Credit for this information was given in the HPI. So the total amount and complexity of data reviewed in this case is 0. In looking at the table of risk for case 2, the patient has 2 stable chronic problems, which is identified as moderate risk, and so moderate is the overall risk for the encounter. When we apply case 2 to the table that determines the overall medical decision making, 2 of the 3 components are met in the low complexity column, which is the furthest to the right, and therefore the medical decision making assigned to this case is low. This case did not contain a time statement. Here are the details of the documentation that was credited for each element in case 2 for you to reference later. Case 2 appears to be an established patient visit, and once again we have met 2 out of the 3 components to support CPT 99213. We had an expanded problem-focused history, a problem-focused exam, and low medical decision making. Case 3 is a patient being seen for insulin adjustment and continuing diabetes education. She is referred by Sally Sitz, ARNP. The patient reports increased stress due to holidays and death of a friend and less routine than normal. She thinks she's been missing more insulin because of holiday snacking and being away from her normal routine. The provider lists the current insulin regimen and that testing times are occurring before meals and at bedtime. The provider states blood glucose history was obtained and to see the OHOM glucose section under labs, but did not provide a reference date for the labs reviewed. This slide shows us the provider's assessment and plan for case 3. The patient has a fasting blood glucose more variable than usual. The average is 144 and the range is 88 through 209. The variability is most likely due to a less controlled evening blood glucose. The pre and post meal blood glucose remain under good control when the patient takes her insulin, but she has been forgetting more often, especially in the morning. She is aware and hopes to get back to her normal routine now that the holidays are over. The patient had hypoglycemia on 4 occasions over the last 2 weeks. 3 of these were within a 3-day stretch, and all of them occurred in the afternoon or evening. 2 of the episodes are explained by the patient mismatching her insulin to carb intake at mealtime. The patient was counseled on a PCP follow-up and an A1C, which is due. She set goals for getting back to her routine for insulin and remembering doses more frequently. She is to continue on the current insulin doses, and the provider lists the insulin doses for the basal, mealtime and snacks, and correction. The chief complaint is documented as an insulin adjustment and continuing diabetic education for case 3. The HPI elements supported are modifying factors because the patient has been missing more insulin. Context is assigned for the holidays. Duration is assigned for 2 weeks, since this is when the hypoglycemia started occurring, and timing is assigned for evening, as this is when the blood glucose is the least controlled. This gives us a total of 4 HPI elements, which would qualify as an extended HPI, and we would circle that level on the table. Under the review of systems, the endocrine system is credited for the variable blood glucose, and the psychiatric system is credited for increased stress. This gives us an extended ROS, and we would circle the 3rd column for this element. Under the past medical family social history, the provider documented the patient's diabetic medications, which is credited as treatments under the past medical history, and this gives us a pertinent PFISH, and we would circle the 3rd column in this element. In this case, we do have 3 circles in the same column, so our history is detailed. There was no exam documented for case 3. Under the diagnosis and treatment options in medical decision-making for case 3, the patient had an established problem which is uncontrolled. We would enter 1 in the number column and multiply that by 2 points, and our result would be 2. Again, this is the only problem addressed during the encounter, and so the total under diagnosis and treatment options is 2 points. There is no work credited under the amount and complexity of the data to be reviewed for this case, so our total is 0. The provider stated that the patient was due for an A1C, but does not state that it was ordered. On the table of risk, the patient has 1 chronic problem which is uncontrolled, and that is assigned a moderate level of risk, and that would be the overall risk for this case. When we apply case 3 to the table for determining the overall medical decision making, 2 out of the 3 components are again met in the low complexity column, and therefore the medical decision making assigned to case 3 is low. There was no time statement in the note. Here are the details for case 3 for the documentation that was credited under each element that you may reference at a later time. In case 3, we had a detailed history which would support CPT 99214. However, the established patient E&M codes require 2 out of the 3 components to be met in order to report the code. We did not have a detailed exam or moderate medical decision making for another component to support CPT 99214, so the code supported is 99213 because we exceeded the amount of history for that code, and 99213 is where 2 out of the 3 key components are met for this case. Case 4 is a patient who is seen in the clinic for a point-of-care INR test. It's a subsequent evaluation with any needed adjustment to the warfarin therapy. The patient has been compliant with the warfarin dose. The patient's medications were reviewed during the encounter, and there have been no changes to his medication or supplements. There have been no changes in the patient's diet or lifestyle and no issues with bleeding, bruising, or clotting. There have been no recent falls or injuries. The patient does report that he will have surgery in 2 days for a hip replacement. He was not instructed to hold his warfarin prior to surgery, and he will let the surgeon know the reading today. There have been no recent hospitalizations or ER visits. The patient's INR is 2.4. The current warfarin dose is 27.5 milligrams per week, which is confirmed by the patient. The current warfarin tablet strength is 2.5 milligrams per tablet. The assessment is that the INR is within the established therapeutic range of 2 to 3 for DVT. The patient was given the following verbal and written instructions, and an understanding of the dose was noted. Continue warfarin dose of 27.5 milligrams per week, 2.5 milligrams on Sunday, Wednesday, and Saturday, and 5 milligrams for the rest of the week. Recheck INR in 4 weeks unless there is a need for earlier INR testing. Results will be faxed or posted electronically for the referring provider's review. For Case 4, the chief complaint is documented as a point-of-care INR test with warfarin adjustment if necessary, and evaluation of the patient's knowledge and education regarding warfarin anticoagulation. The HPI elements supported are a modifying factor because the patient is compliant with the warfarin dose. This gives us one HPI element, which would be a brief HPI, and we would circle the second column. Under the review systems, the hematologic system is credited for no bleeding, bruising, or clotting issues, and this gives us one system review, which is a pertinent ROS, and we would circle the third column. Under the past medical family social history, the provider did document that the patient has not had any recent hospitalizations, as well as the current dose of warfarin, and this gives us pertinent past medical history, so we would circle the third column. We do not have 3 circles in the same column, so the circle farthest to the left identifies the history, which is expanded problem focused. No exam was performed or documented for Case 4, and even though the INR result is listed under the objective section, this is not counted as exam. This is counted under medical decision making as a lab review in the amount and complexity of the data to be reviewed. Under the diagnosis and treatment options for Case 4, the provider states that the anticoagulation is within goal, which would be worth 1 point under the established well-controlled problems, and so our result is 1, which is also the total for this element. Under the amount and complexity of data to be reviewed, 1 point is assigned for reviewing the patient's INR, and 1 point is also our total for this element. In the table of risk, warfarin is a drug therapy which requires extensive monitoring for toxicity and can be considered high risk under the management options. So the level of risk assigned to this case is high, even though under the presenting problems, the patient's problem would qualify as low for one stable chronic illness. When we apply Case 4 to the table that will determine the overall medical decision making for the case, the only column that we have more than one circle is in the straightforward column, and therefore our medical decision making is straightforward, even though the risk assigned to this case is high. For Case 4, the history exceeds what is required for a Level 2 service, but we did not have enough exam or medical decision making to meet the other required components for billing 99213. Therefore, the code documentation supports 99212 for this case. Case 5 is documented in an APSO format, which means that the assessment and plan come first in the note, followed by the subjective and objective information. The assessment is a newly diagnosed diabetic with an A1C of 12% who verbalizes motivation to make some changes and is feeling overwhelmed with the news. The patient was reminded of the PCP's medication regimen plan. He was asked to check blood sugars fasting, 2 hours after breakfast or lunch alternating, 2 hours after dinner, and when feeling low. The signs and symptoms of hypoglycemia and how to treat it were reviewed. The eventual blood sugar goal is to have the fasting blood sugars between 80 and the 130s and the postprandial less than 180. The goal is to get him there step by step while minimizing harms. How the medications work and the potential side effects, as well as the onset of action, were reviewed. The patient was provided a color handout for plate method. 45 to 60 grams of carbs per meal and at least 30 minutes per day of exercise were suggested based on ADA recommendations. The provider pointed out that the patient needs a little more veggies and protein with breakfast and lunch, and definitely more veggies with dinner. The patient plans to eliminate soda and juice effective today and is able to demonstrate how to use the glucometer and how to draw up insulin and inject using the dummy tummy. Follow-up will be performed by phone on Monday. The patient is attending the visit with his wife. He states he finished a visit with Dr. X and picked up his medication and insulin from the pharmacy but left them in the car. He reports a fear of needles and that his brother and grandfather have diabetes. He states he feels a little overwhelmed because he thought he was invincible. He endorses polyuria, polydipsia, and fatigue. He is between jobs, but his previous job as an analyst was a sedentary job. Breakfast consists of 1 packet of ramen with chicken sometimes. Lunch is 1 salami sandwich with chips and soda. Dinner, some kind of protein and rice or potatoes. He drinks black coffee, 3 to 4 sodas a day, and occasional juice. He admits he generally does not eat many vegetables, but states he likes spinach, carrots, green beans, peas, and some salad. Current exercise is minimal. He used to walk up the hill to get to the food truck when at work and walked around at work, but no additional activity. The provider and patient spent extensive time reviewing pathophysiology, how insulin and glucose work, hyperglycemia and hypoglycemia signs and symptoms and how to treat them, the importance of lifestyle and behavior changes, and long-term side effects of uncontrolled diabetes. Glucometer training was also discussed with the patient for using the Lancet device, storage and expiration of the test strips, how often to check their blood sugars, and how to dispose of the Lancets. Insulin education was also provided. The patient's medications were reviewed and confirmed to be correct without any changes since the patient's last visit. The most recent A1C was reviewed, which showed 12. 45 minutes was spent face-to-face with the patient. Greater than 50% of the time was spent counseling regarding diabetes, checking blood sugars, lifestyle and behavior changes, diet and exercise, use of the glucometer and insulin, and the signs and symptoms of hyperglycemia and hypoglycemia. So this note has a time statement documented. Let's see if we can answer yes to all of the questions on the auditing tool under the time-based billing assessment to see if time can be used as the controlling factor for this case. The chief complaint was also documented for case 5. And remember that this element is required for every evaluation and management service, whether it's coded on complexity or time. The chief complaint was listed as a newly diagnosed diabetic with an A1C of 12%, verbalizing motivation to make some changes. We do not need to calculate the history exam and medical decision-making for this case because the provider's note documented the total face-to-face time, the amount of time spent counseling, which was greater than 50% of the total time, and therefore we know the encounter was dominated by counseling and should be coded using the amount of time, as the provider did an excellent job of documenting the details of the counseling content. Case 5 is unclear if it is a new patient visit or an established patient visit, And so we would check the records to see if this provider or another provider in the same group had seen this patient in the past 3 years. If not, we could code 99204 for a new patient visit, as the typical time assigned to that code is 45 minutes. If this was an established patient visit, the highest code in that code family, 99215, would be reported as the typical time associated with that code is 40 minutes. Here are my sources for this presentation. I strongly recommend that you read them for yourselves for a thorough understanding of the guidelines. If you work for a healthcare organization and have a coding or compliance educator available to meet with you, I would encourage you to do so to make sure you are compliant with the organization's policies and procedures. Thank you for listening to our session about auditing medical records. I hope that it has helped you to understand the documentation requirements for complexity and time-based services, and how clinical information documented in the medical record is counted to support each element of an E&M code.